Well, great. Good morning, everybody. And thank you first to John for having me. As some of you may know, John and I worked together for many years at the Beth Israel. And I still remember as a chief medical resident being in the command bunker with you on 9/11, expecting tens of thousands of patients to come up from New York, which unfortunately never came. But I remember your leadership on that day and really benefited from all of your insight and counseling since then. So thank you for having me here. Thank you also to the VA for the work that you do. I am profoundly grateful for the sacrifices that our veterans make every day on our behalf. And so it's a real honor to potentially play a tiny role in helping make their lives better. For full disclosure, we are a member of the Cerner Code program and work with them with clients across the country. So I wanted to mention that, and I'll come back to that a little bit at the end. But I actually wanted to start this morning with the inspiration for Kyruus, which was actually the movie Moneyball, which some of you may know from the sport of baseball. Moneyball was reflected very much of the family values that I was brought up with. We're all different. We're all beautiful in our own way. We all have our relative strengths and weaknesses. And what baseball figured out was that you could understand relative competencies amongst players by looking at data, by looking at statistics and understanding what it is that people did well and then putting them up to bat in situations where they were more likely to do well and the team would therefore benefit by playing to their strengths. And I became convinced that physicians were just like baseball players. They all had their relative strengths and weaknesses. You might be better doing hip operations than you were knee operations. And we had a lot of statistics and data about physicians. Could we begin to understand physicians at that kind of granular level and put them up to bat or match them with the right kind of patients? And the promise of being able to do that was potentially to really transform the way we routed patients to providers. When I was growing up, we often had a go-to ortho guy that we sent all of our cases to. And the reality is, as medicine has matured and subspecialized and networks have grown, there is no such thing as a go-to ortho guy. There's now a hand person, a knee, and a shoulder, a foot and ankle, et cetera, et cetera. And as all these systems have come together on disparate IT platforms, it's very hard to know who is the right provider anymore to send a patient to. And so we got really interested in this idea of how can we, in fact, inform a match in real time and at scale. As we've talked about over the last couple of days, it's actually very complex because the patient cares about lots of different things. They'd be more comfortable seeing a female provider who speaks their language, maybe has availability on a morning they've got daycare coverage. Obviously, it's to take their insurance, be close to their home or work, all those kind of things. The providers, as we've talked about, they're all different as well. And as some people pointed out, they actually may look different in different offices. They may have access to different equipment in one office versus another, or take different insurance products in one office or another. They're often subspecialized, have access to different language services as well. And as we also engage, as we do today in the commercial market with different health systems, many of them are trying to figure out what business they're in as well. And do they want to preferentially route and steer patients to their employed doctors before their affiliates, to the brand new doctor who's got availability before Dr. Famous, who's queued up and waiting for weeks anyway, or to people who specialize and do different kinds of therapies for different kinds of care. And what makes this challenging for everybody, of course, is that this is changing in real time all the time, right? And so if I need a flu shot, what's important for me today is probably down the street today for $10. If I need a bypass operation, I'm going to prioritize a completely different set of criteria. And so you need a system to be able to accommodate that searching and routing across everything. So I had to smile many times over the last day or so as people were bringing up the travel industry, because that was really what we began to look to as a model for this. And when I'm on panels a lot, I'll joke about the fact that in healthcare we don't really have to invent anything. We just have to look at what everybody else is doing in the 1980s, right, and bring it forward. And it turns out in some ways this is actually a solved problem. And if you rewind back to 1990 in this country, every time an airplane took off, 4 out of 10 seats were empty. And it turns out we actually see that in many of the health systems we do today, that we think doctors are busy and there's this huge wait time, but oftentimes 20, 30, 40% of the appointments are actually empty every single day, right? Not evenly distributed. Dr. Famous is in fact 100% booked up and out for 17 weeks, and that's who everybody knows and keeps sending cases to. But there are brand new doctors, or there are Friday afternoon slots, or community slots that are actually underutilized, right? And so there's this complete supply-demand mismatch that the airlines thought about as well. And so the analogy we thought held, at least at a high level. You have a fixed cost asset, right? A huge airplane with rows and rows of seats. It looks like a physician network with rows and rows of appointments. All the planes are different. One goes to Chicago, one goes to Miami. In our case, one's a hand surgeon, one's a knee surgeon. And what transformed seat utilization in the airline industry was the Sabre system that ultimately became the likes of Travelocity and Kayak. But basically what they did was create a digital inventory of the seats. So now you could look across American Airlines and JetBlue and Continental, the same way a modern health system needs to look across doctors on Epic and Cerner and Athena. You can sort and filter by business logic. So if I want to take off after 9:30, sort by price, or in our case, see a female provider, speak Spanish, and sort by availability, basically find and fill seats within the health system. And so that really became the platform for what we do today. And so our product stack starts off with a data management layer. It turns out a lot of that data exists, but it exists in a lot of different places. And so we aggregate all that information and create that digital inventory of who does what, where, when across the system. We've enriched that with a 20,000 term library of terms so that now you can search for AFib or AF or atrial fibrillation misspelled. All of that routes to the same provider. So you don't have some doctors who get AFib and others get atrial fibrillation because they filled a form in differently, right? All that needs to go to the same provider. And that allows us to again, begin to do that routing. And then we drive that data into an application layer that allows call center agents, that allows patients themselves on the Find a Doc, or referring providers or ERs in the point of care to now find and route patients to that right provider. So I'll touch base on a couple of the core pillars of the company, and then John will show off a little bit how we've been able to tap into a lot of these standards has allowed us to really create a product for patients to use. So at our core, we're a data management company. At one point, as we were building this, we're 6 billion data points a day coming in from 1,600 unique sources. And we applied a lot of machine learning techniques early on to understand that when you saw an article by G. Gardner at brown.edu, and you could parse it and see it was on atrial fibrillation, that was likely the Graham Gardner, who trained at Brown, who was a cardiologist of which AFib's a condition, and not Gordon Gardner, who was an OB-GYN in Texas. And so that was a lot of how we built the entity resolution and the ability to kind of populate profiles that now have about 200 different data elements across video and personal statements, their clinical scopes of practice, their insurance, locations, et cetera, et cetera. So that's what we do really on the supply side of understanding the provider landscape. One of the things we had not anticipated, but has hopefully been something that we can contribute now to the solution, is the ability to read and understand availability across multiple systems. And as people have talked about, as we began to kind of engage with health systems that were on multiple EMRs, there were in fact 8,000 appointment types on Epic, and there were also 6,000 on Cerner and 4,500 on Athena, et cetera, et cetera. And for those of you who've been in the guts of this, I mean, it's NUPAT space dash, space cards space dash 15 min, which is different than NUPAT without a space dash cardiology, space 15M. And so, bringing that together was actually a lot of work and a lot of semantic manipulation that went in, because at the end of the day, all the consumer cares about is this is a new patient appointment, right? And they don't want to sort through all that stuff. And so we've done a lot of work in really understanding the guts of these systems and be able to kind of populate availability in a way that still actually respects the underlying rules, but makes it available for a consumer and referring providers to sort through. So we're fortunate today to partner with a lot of health systems around the country. We typically only target the top 400 health systems, so many of these organizations have 20,000 or more providers, and have about experience now with about 225,000 providers across the country. And so as we begin to think about the ability to route into the broader community, we've been fortunate already to have a lot of those folks on our system. But I think one of the other important parts of what we do is actually engage with a lot of other players in the ecosystem. And our vision statement at Kyruus is to enable human beings to care for other human beings. And the human beings is in there twice, again, from a Moneyball perspective, to recognize the fact that both providers and patients are different and need to be understood in order to inform the match. But enabling is a very important word for us as well. It's to remind us of our humility that we're not the be-all, end-all. We are an enabling technology platform that a lot of other work has to go into, both from a change management and cultural perspective, but also from an IT integration perspective as well. And so as I mentioned, we're part of the CODE program, part of the Epic App Orchard, other EMR development programs as well. We think there's an important role to play around interoperability, around just that ability to route and schedule on top of that, but then to begin to plug in lots of other solutions like CRM, where you are going to pull the patient's preferences from and have that be part of the search. From a chat experience, so you can actually enable virtual care initially on the phone before you escalate that to a provider. And as I'll talk about, also engaging listings management, telehealth, and the ratings and reviews as well. So I wanted to finish with a couple of slides here that hopefully begin to paint a picture of where we can go. Recently, one of our clients, Piedmont, down in Atlanta, created a video that showcases the booking availability there. It reminded me of a passage from one of Thomas Friedman's book when he talks about what APIs did for us in kind of our modern culture. And for those of you who have ever shopped on Amazon now, you can either with facial recognition or a thumbprint, open up your phone, get onto Amazon. It knows exactly who you are. You're able to look at inventory from dozens and dozens of different manufacturers. You're able to buy something with one click. It's automatically deducting money from your bank account. It's drop shipping that to your door, and just really transformed the way in which we can engage with e-commerce. So if you don't mind maybe clicking on that buy now and then opening up this video, you'll begin to get a sense of how patients are able to schedule now in Atlanta as well. Well, so again, this is not just us, and if you just go to the last slide, this is all made possible by APIs. And sorry if you can't necessarily read all this, but what the work that we do is first of all through Brandify and other SEO optimization strategies, we get people to Piedmont the first time, right? So they're initially just consumers that you want to be able to attract to the website. Then you want to be able to convert them into the right seat, right? And so we integrate all those dozens of different credentialing and privileging, marketing databases, insurance databases that you can have that customized search, look at videos of patients, or excuse me, of providers, and bring that together. We're then pulling all of those appointment types. So if you say I'm on a new patient or a follow-up, we know exactly what that means. We can pull that out of the schedules, and we can show, to someone's point earlier, availability both at your 3 different locations. You can see on one screen all those locations and compare and contrast providers. We then do patient registration as well through many patient reg using FHIR APIs. And then when you close that, we're able then to push that information out to appointment schedule reminding companies so that they can then begin to kind of close that loop as well. And so all of that really kind of enabled through modern APIs. And thank you to the work you did in facilitating that, John. So go ahead.
So just some quick remarks about what Graham has shown us, then I'll introduce the deal. So it turns out this morning, this happens to me every day, I'm sure it happens to you, some colleagues in China said, I have a man who has stage 4 colon cancer, and I need to send him to the Beth Israel Deaconess to see the absolutely best person who knows stage 4 colon cancer and can see him within 2 weeks. And here's his entire medical record sent over email. Not that sending your medical record over email would necessarily be something I recommend. So what did I do? Well, I did probably what any of you would do, which is that because I've been at Beth Israel Deaconess in Harvard for 30 years, I know the 3 people I can ask about cancer. So I emailed each of those 3 and each of them, oddly enough, came back and said, Dr. Andrea Bullock is the person at Beth Israel Deaconess who knows stage 4 colon cancer better than anyone else. And then what I did is I contacted the CEO of HMFP, our faculty practice, and said, I need Dr. Andrea Bullock to see this patient within 2 weeks. And by the way, this is a person from China, and I'm not quite sure how we're going to arrange any financial transactions. So then she delegated to the chief medical officer of the faculty I tell you this because this is unfortunately how things work in America, right? And so shouldn't you be able to do what Graham said, is that instantiate a set of rules that say, actually, we don't have to have this network of friends and family. There can be systems that figure out who knows stage 4 colon cancer better than anyone else, and if they have an appointment availability, and if they would take an all-cash patient from China or not, right? But there's subtlety. And let me just riff on the subtlety for a second. So a week ago, I had a patient who said, oh, I got this vague abdominal pain, and I've been to 12 doctors, and none of them have been able to solve my problem, and I have Mass Health. And I need to see somebody who can deal with vague abdominal pain and accepts Mass Health. Well, it turns out that the best doctor in our system to see this patient was Dr. George Barnett at Milton. And Milton, it turns out, doesn't take Mass Health. And so what did I do? I called Dr. George Barnett and said, this is my best friend who's got vague abdominal pain, and you are the best expert ever. Would you agree to take Mass Health? He said, sure. Send him down tomorrow. Right? So I tell you all this because it's just complex. And they'll do a great job instantiating rules, using machine learning, and being very agile. But on occasion, of course, there are humans that still need to be involved. So what I say is machine learning will solve many problems, but there'll still be humans to deal with the edge cases. Now, humans are very unpredictable characters. And so let me introduce Adil Yang. Even though we decide that we are going to see a given specialist referred by Graham because that doctor is both available, takes my insurance, and, by the way, knows my particular problem or symptom very well, it is unfortunate, and you've already said, I'm a young male with not a lot of comorbidities. Why am I not showing up to this appointment after I've worked so hard to schedule it? The answer is it could be complicated. It could be transportation, or it could be a social determinant of health, or who knows. So Adil will tell you how now he takes the next step after the appointment has been identified to ensure the patient gets to the right setting of care, to the right provider, at the right cost, at the right time, and fills the schedule that Graham worked so hard to set up.